Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
My name is Stephanie, and I'm an intern here at the Blum Center.
Before I get started, I just want to go through a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has music and here guest speakers today. If you have any questions for our guest speakers, you may use a chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. So next, I'm going to turn it over to Stephanie, who will introduce you all today's guest speaker.
Joining us today, we have Tessa Kennedy and Simona Lourekas. Tessa is a pediatric speech language pathologist with the Department of Speech, Language, and Swallowing Disorders and Reading Disabilities at Mass General for Children. Simona is a clinical nutrition specialist with a gastroenterology and nutrition at Mass General for Children. In recognition of National Nutrition Month, they are here today to give a talk on tips to develop children's healthy eating and feeding skills. Please join us in welcoming Tessa and Simona.
Let me start sharing some slides. We can get started. Let Tessa get started if that looks okay.
Yep. Thanks, Simona. All right. So today we're just going to talk about some strategies for both starting solids and kind of how we manage the most common pitfalls and all the things that come along with it. So, Simona, if you want to go to the next slide, I'll get a little into my background, and then Simona can give you a little bit of hers. My only financial disclosure is that I receive a salary from Mass General. I got my master's from the Mass General Institute of Health Professionals, and got my clinical fellowship in the early intervention setting. And then I've worked at Mass General for, I think it's actually 7 years. It's a long time. And I evaluate and treat patients with feeding and swallowing disorders, both in sort of individual settings and clinical feeding evaluations, and as part of some multidisciplinary teams like the Down Syndrome Clinic and the Feeding and Nutrition Center. And I treat patients from birth to adolescence with a pretty wide range of presentations.
And I'm Simona. I received my master's in nutrition from UMass Amherst while I was working at Bay State Children's Hospital in a community nutrition program. Then completed my dietetic internship training at Brigham and Women's Hospital and some other medical centers in the area. Worked at another pediatric facility, and now for the past almost 4 years, have been working at Mass General Hospital for Children in several multidisciplinary clinics that I've listed here. And here's an overview of what we're going to be discussing today. And then I will hand it back over to Tessa.
All right. So the age range for starting solids is between 4 and 6 months. But more than age, we really look for readiness. So there are a few things we look out for, and we really want all of them to be in place before we're starting solids. We want babies to be able to sit upright with pretty minimal assistance. So they don't need to sit up totally unassisted, but the idea is that they, if they were put into a high chair, they wouldn't be slumping, slouching, having to use their elbows as support. They could maintain a pretty good upright position on their own. And we also want babies to have good enough head and neck control that they can hold their head upright without the little bobble. And that would be for sort of the duration of a meal, maybe 5 or 10 minutes that we would want them to be able to do that. We also want babies to be able to bring objects to their mouth like teether toys, because that's really going to help with self-feeding and shows us they're ready to bring a spoon to their mouth. And finally, we want to see babies are actually interested in food, what we're eating, following it with their eyes, moving their mouth when they see us eating, leaning towards the food. Sometimes they are grabbing at your food, but we want to make sure, and all of these motor things are important, but it's also super interested that they are important, I should say, that they're interested and they actually are showing us they're ready. Um, as a quick note, if babies are premature, we typically want to wait until they're 4 to 6 months corrected, meaning we're kind of taking that how early they were into account. So, for example, if they were a month early, we just sort of shift that to 5 to 7 months corrected, or 5 to 7 months because we're correcting for that month that they were early. Um, Sometimes I have families say they start solids, but their babies didn't seem to like them, so they stopped for a few weeks or months. That can be totally okay if we're introducing closer to 4 months, but we don't want to go past that 6 month mark, except in that case of prematurity, because 6 to 9 months in particular is a really critical time period for sensory integration, oral motor skills development, how babies are learning to process flavors and textures, and how they're learning to use the structures of their mouth to chew and move food around. If we wait too long to introduce solids or we wait too long to advance to the next texture, we can sometimes run into issues with like delayed biting and chewing and oversensitivity in the mouth. So we want to take advantage of this like time when babies are primed to learn these skills, and that's definitely in that 6 to 9 month range. Next slide. All right. So setting up the right environment is really important for successful feeding. We want to make sure that babies are fed upright in a supportive high chair with foot support. This is like my biggest pet peeve, that all the high chairs out there are made for like a 3-year-old with the foot panel like way, way down below. The reason that it's so important to have their feet planted is that it gives them support all the way up through their body. So their feet support their knees, which supports their hips and their trunk and their head and neck, jaw, and then finally those small muscle movements of their tongue. And if they aren't having that support, it's a little bit harder for them to coordinate those movements. If their feet are dangling, it can also just impact their attention to the meal as well. So picture when you're at a restaurant and you get sat on a bar stool and you're just like constantly trying to find somewhere to put your feet. It's a little distracting. So it seems like a little bit of a unimportant detail, but I think it's really important they have something under their feet. And Simona, there's a picture on the next slide if you want to go to the next one. Perfect. This is a really great example of a baby in a perfect position. So you can see they can reach straight across to get their food. They don't have to reach up. They're not too low. And then we've got this really nice 90-degree angle at their hips and at their knees. So that's what we're looking for. Next slide. From the very beginning, promoting self-feeding is super beneficial to the baby and really beneficial to parents. So self-feeding promotes independence and fine motor skills, but even more important than that is this ability to be in charge of what goes in their mouth. We know gagging is really normal with the introduction of solids, which I will talk about in a few slides, but we also don't want gagging to be really frequent and persistent. And babies who are primarily feeding themselves are less likely to gag, which makes sense when we think about it. How it would feel to be fed by someone else or to have your teeth brushed by someone else, for example, not quite as pleasant a sensory experience as if we're doing it ourselves. Getting baby-friendly utensils can be really helpful. So we want them to be able to hold on to them with that chubby fist. So the short, fat utensils are my favorite, as opposed to the kind of skinny, long ones that are better for feeding babies. I tend to find if babies are having those long, skinny ones, they're going to poke themselves in the eye when they're trying to get it to their mouth. The short, fat ones are a lot easier for them to use themselves. Oftentimes when I'm feeding babies at this age, I'll have 2 or even 3 spoons that I'm kind of offering in a rotation, preload one and give it to them. Once that spoon is cleared because either they ate the food or they took it off with their hands or they threw the spoon, then I have the next spoon kind of ready to go. Sometimes they like to have one in each hand. That's why I'll have three. And just sort of keep them in the driver's seat, even though I'm kind of prepping it for them. Next slide. All right. Messy exploration. So this can be so challenging as a parent to watch our babies get absolutely covered in food during the meal. Um, Sometimes it can feel wasteful. Sometimes we worry that like none of it's getting in their mouth and it's all going into the seat and on their body. Sometimes we have our own sensory reaction to seeing food all over the place and the mess is really triggering. But as much as possible, we really need to allow our babies to get food on their hands, on their face, in their hair. I know it's hard, and leaving it there. So resisting the urge to wipe their mouth between bites. Again, kind of picturing how that would feel if someone was doing it to you. And the reason for all of this is that eating is one of the most sensory rich experiences that we have, which can also mean that it's really overwhelming. So, getting messy allows babies to experience and begin to process all of that sensory information, the way that it tastes, the different textures, smells, the way it sounds when they're squishing it in their hands. The more experience they have, the less sensitive their body is to that sensory information. If we're not allowing them to touch foods or have food on their hands and their cheeks everywhere, their body isn't able to adjust to that, and that kind of big reaction to that sensory input might persist a little bit longer. Next slide. This is what I want the baby to look like. So pretty messy, and this is like my dream. This is a perfect feeding for this little one. Just a note about food waste, particularly I think right now, that's on everyone's mind. By definition, this approach is going to lead to wearing a little bit more food than we're consuming, perhaps. And that can feel really wasteful sometimes. So I like to think about this in the same context as other learning that we allow our children to do. So when kids are learning to draw, they might make a couple of marks on a piece of paper and then that paper gets thrown out or recycled. We don't necessarily consider this wasteful because they're learning important skills that are eventually going to support writing and drawing. When kids are potty training, we can go through a lot of toilet paper, more than they're going to need eventually, and that's just sort of the cost of learning. So I think about the food on their bib and stuck in the high chair and everywhere but their mouth as part of this like crucial learning experience for them. Obviously, there are ways to mitigate this. So, like giving them 1 ounce of puree on their tray instead of the 4 ounce jar, because we know they're going to take that jar and dump the whole thing, right? Instead of giving them 10 raspberries, we can just give them one, and watching that get thrown on the floor is a little less painful than watching them windshield wiper off the whole 10 that you just gave them. So, there are ways to mitigate it, but I do like to kind of contextualize that as part of this learning process for them. Okay, I'm not going to spend a ton of time on baby-led weaning today just because that could be a whole talk of its own, but I will just talk about a couple of key points. So baby-led weaning is only appropriate for babies who are 6 months or older. So it can be done alongside puree and does not need to be an all or nothing approach. And there are some really great resources. Solid Starts, which is a website and an app, is one of my favorite that offers guidance on how to safely offer the foods that you're eating as a family. One of my favorite aspects of baby-led weaning is that babies are exposed to the foods and flavors that the family is eating, but that can be possible with purees as well, right? Blending up the foods you guys are eating for dinner. The absolute most important thing that I want to let people know about this kind of question, which one should I do? By about 9 months, baby-led weaning and traditional weaning, meaning starting with purees and then kind of adding in chewable foods, that should look extremely similar at around 9 months. So that brings me to kind of a brief texture timeline, and we can talk about what that would look like. So again, for this, I'm going to focus on traditional weaning. There are resources for baby-led weaning if you want to go that route. This is also very general. So if you have questions about any specific step, that really should be discussed with your child's provider specific to them. Between the ages of 4 to 6 months, again, babies should only be offered puree if they're starting solids at that time. Purees and baby cereals should be offered on a spoon and not in a bottle, unless that's something that you're specifically guided to do by their doctor or feeding therapist. Around, next slide, Simona. Around 7 to 8 months is a great time to introduce crunchy dissolvables like a teether cracker or a peanut puff. Puffs or yogurt melts are an option a lot of parents go for. To be honest, I see a lot more gagging with these because they're smaller and they're harder to manipulate for babies who don't really have the skills to move those smaller things around in their mouth. It doesn't mean they're any less safe. They just tend to kind of like stick in the middle of the tongue, and then we see a lot more gagging. So just a heads up on that. So I tend to stick with the bigger options that are either like a French fry shape or a surfboard shape. So so that they can have a little more control over them. The texture melts in your mouth with your saliva almost to a puree kind of consistency. So it's a safe way to begin working on the biting and chewing skills, and one that I think a lot of parents feel a little more comfortable with. So I think it's a really, really nice option. When you're offering soft solids at this age, you can do a squish test to kind of help you decide whether it's a good food to offer. So, for example, if you pinch a raspberry between your fingers, it will squish really easily. That's what they're going to be doing either with their gums or with their tongue against their palate. If you try to squish like an out of season or unripe strawberry, it's not going to squish. It's pretty hard. So that would not be a good option for them. So things like avocado, banana, salmon, like all of those types of foods are squishable and a nice option at this age. By the time they're 9 or 10 months old, most babies are ready for bite-sized pieces about the size of sort of the top of your thumb. This readiness oftentimes coincides with the development of their pincer grasp, which is this movement here, kind of what we think about with them picking up a Cheerio. It's also when we're starting to see babies' tongue lateralize to the side, meaning like moving food from the middle to the side. So they're using their molar surfaces, this side here, to chew. It's really important to note that babies do not need teeth to move on to chewable solids. All their teeth are right under the surface, and they have very strong jaws. And I'm sure if you've ever stuck your finger in your baby's mouth, you know they can bite you really, really hard, even if they don't have any teeth in there yet. The last of their teeth are not coming in until close to their 3rd birthday, and we certainly aren't waiting to give them all these wonderful foods until that age. So it's a really common misconception out there that the more teeth they have, the more ready they are. And if they don't have teeth, they're not ready. There's no correlation, and I don't want you to worry about that when you're thinking about next textures. Many babies, I might even say most babies, are not a big fan of the mixed textures like stage 3 baby foods or chunky purees. It's totally fine to skip over this texture entirely. It's not developmentally necessary to kind of go through like stage 1, stage 2, stage 3, and then they can have table foods. Most babies are totally fine to go from a smooth puree straight to table foods, and that's completely fine to do. This is a really important one. So when you're starting solids or moving on to a new texture, gagging is a really common occurrence, and it's not something that I want you to panic about. I often recommend, number one, take a CPR course so you feel super confident about what to do if your baby were to choke. And number two, go on YouTube and watch videos of babies gagging so that you also know what does normal gagging look like. I think it's really helpful. Gagging is not the same thing as choking. It's a normal protective reflex in babies. And the gag reflex can be triggered much further forward in the mouth in a baby. So they may have something sitting on their tongue that triggers a pretty intense gag that can look really scary, even though there's nothing in or near their airway. It's really a protective response that their body goes, this is new and I'm not sure if it's safe. So I'm going to like lift the tongue and push it forward so I can get it out. And again, they're not in any danger during any of that process. The best thing to do when your baby gags, even if you're having an internal panic attack, which is fine, is to keep your face and your body calm, talk it through with them in a really neutral, calm voice. Great job. Keep chewing, spit it out, whatever you need to do. If they see you panic, then they're going to panic. So stay nice and calm, sit on your hands, whatever you have to do. You don't need to pat their back. You don't need to take them out of their chair. Please don't put your finger in their mouth. That can actually push it back further and put them at risk for choking. But most babies are going to work it out on their own. So you don't have to do anything at all. And I do have a video. Hopefully this video works, of my son when he's about 7 months that's a pretty good gag that we've got. Does that seem like it's working, Simona?
Here, let me see if I need to adjust the screen share. Yeah, it's here. Let me stop sharing and then start sharing another screen that has the video in a second.
Okay, awesome, thanks. So this is really helpful because, again, it can look pretty dramatic, right? They can turn red, they can turn purple, they can have tears streaming down their face, they could be coughing, retching. It looks really intense, but they are safe and just fine.
Yeah, play just the beginning part again because I think my mouse is blocking a little bit of it.
So when you're seeing that for the first time in your baby, you might initially think, oh my gosh, they're choking. They're like, this is a huge emergency. It's completely fine. He ended up just spitting that out and moving on. And it's a really very normal and it will happen. So just be prepared. All right. So I will just quickly talk about general timeline for introducing cups. Again, this is specific to your child, but for the most part, babies are ready for straw cups or an open cup to start practicing with them at about 6 months old. So just a quick note about sippy cups. There is nothing wrong with them. You can absolutely use them. If you have older kids and you already have a sippy cup that you like, that's great. If you have one that a friend gave you, they're already using it, they love it, fine, no problem at all. The main reasons that I introduce a straw cup, number one, it can be beneficial for oral motor development and kind of working on those muscles. And number two, straw cups are something we use as an adult. So just as sort of my personal experience from parenting, you put all this effort into weaning them off of the bottle onto something else. I personally would rather wean them onto something that they can use forever versus a sippy cup that also eventually we will have to wean them off of. So that's why I tend to recommend a straw and an open cup, but sippy cups are totally fine. Excuse me. I'm happy to provide a resource on how to go about introducing an open cup or a straw cup if anyone's interested, but just in the interest of time, I just wanted to mention a timeline for that. Kind of 6 to 9 months is a nice time to introduce it. Utensil use, generally speaking, I want babies to be exposed to having utensils on their tray right from the beginning. So again, giving them that spoon to feed themselves at most meals. With older toddlers, having a fork and the spoon available to them is great. But that being said, expectations for independent utensil use, that's a little different. So typically between 6 and 12 months, they're able to bring a preloaded spoon, meaning one that you've already put something on, and feed themselves with that. They may want to scoop puree with their hands and use their hands to feed themselves table foods. That's totally fine. 12 to 18-ish months, again, this is so variable depending on the child, but 12 to 18 months, generally speaking, we're seeing more dipping into the puree texture and bringing a spoon to their mouth. 18 months to around 2, we're seeing more scooping and bringing to the mouth or maybe starting to stab with a fork. And then from about 2 to 3 is when you might start to see that really strong independent utensil use skill. And again, that might come earlier or later, but that's the general range. And I think it's important to keep in mind toddlers are going to want to feed themselves with their hands, depending on the food, and it's totally normal. So the best thing to do, make sure that those utensils are available at every meal. It can be helpful to preload a couple bites onto those utensils so they can get used to sort of the motor pattern of bringing it to their mouth. But it's completely fine if they like to switch back and forth up until like even 3 years old. Simona, I think you had this last bullet, if I'm not mistaken.
Yes, yeah. And I guess we'll talk more about this on the next slide, but at 1 year, then we'll think about transitioning to milk. The American Academy of Pediatrics guidelines are from 1 to 2 years, 16 to 24 ounces a day of whole cow's milk. And then after 2 years, 16 ounces per day of a low-fat milk. And then if we're dairy-free, the closest nutrition equivalents would be soy or pea milk that's fortified with calcium and vitamin D. And keeping in mind that, solids are complementary for infants, and the water that we talked about is mainly just for practice with drinking with cups. And this is because we've got, limited stomach space at this age. We don't want to, take up a lot of the space with solids and water because that would then, sort of affect our intake of breast milk or infant formula, which has all the important nutrition and hydration that babies need. And we want to focus on adding iron-rich solids, especially for breastfed babies, like things like beans, meat, iron-fortified baby cereals, and then also get in there some healthy fats, fruits, and veggies. And then allergens is a question that we often get, as now research is showing that it's helpful to add in some of these top allergens, especially, research for egg and peanuts before 1 year of age. And we typically start this once the baby is tolerating a few, non-top allergen foods, just so we can kind of make sure that their body seems ready to be starting solids. And then you can, speak with your pediatrician as well for more details about introducing allergens, especially if your baby is higher risk. So has a history of eczema, has had allergic reactions to other foods. There's lots of family members with food allergies. And then for the top 9 allergen foods, so all the other types of foods, now the recommendations are that if the infant isn't, in that high risk group for allergies, that you don't have to, wait a few days between every single new food, in part because that would, take a very long time to get every single food in there. And then keeping in mind as well, when you're, trying some of these top allergens, that it's fine to mix them with a food that we know that the baby has tolerated a few times, like mixing peanut butter with a previously tolerated, pureed fruit or a baby cereal. And then things to avoid for infants, honey, things with lots of added salt and sugar, a teeny bit is okay, but just avoiding high amounts, juice, and then regular cow's milk. That's for, once we're a year of age and older. And then we want to avoid choking hazards. So we want to cut and quarter, grapes, cherry tomatoes, cherries, hot dogs, sausages, raw baby carrots, and, avoid some things like whole nuts, popcorn, tortilla chips. I don't know if I missed any, Tessa. Yeah.
Hard candies. I don't think you're going to be offering those anyway.
Yeah. And then what is, considered age appropriate? So inconsistent appetite is a very common one. So we try to look more at their nutrition throughout a whole week and not so much on one specific day or specific meal. We expect a lower intake for about 1 meal a day, or to have one day where we're eating less and then the next day having more. And then also, I know this time of year, there's a lot of illnesses going around. So we do expect them to eat less when they're sick, and we mainly want to focus on hydration then. And then often they, kind of compensate for that by, eating more once they're feeling better. And then I'll pass it over to Tessa.
Yeah, so selectivity, I hear this all the time. I had the best baby. They ate everything under the sun, anything I offered them, and then they turned a year old, and all of a sudden that went out the window. Around 12 to 18 months, we can see very commonly an increase in selectivity with new foods or even with foods that babies used to really like. So this is normal. There are some things we can do to sort of shorten up this phase and things we can do to prolong it, which we'll get into. But it's very, very typical for this age group. Other things that are expected, throwing things, food, plates, utensils, cups, etc. frustrating, but also really normal. They're really just testing gravity. They're getting a reaction out of the people around them. The best thing to do is keep your reactions minimal and put the dog away, and that's really all we can do to get through that phase. Um, Short attention spans, babies and toddlers have about a 2 to 5 minute attention span per year of age. So many kids will happily sit and eat for longer than that. But if your child only wants to spend 5 minutes on a meal, that's pretty normal, and not something to really worry too much about.
And then for division of responsibility, a dietitian, Ellen Satter, created the division of responsibility model, where this talks about, what's the parent's responsibility, what's the child's responsibility, to kind of help everyone know their role. So keeping in mind what your child eats, how well they eat, doesn't define how well you're parenting, and that, some of the expectations on the parent are to maintain the structure of the family meals. And most children will be ready to join in with that meal and snack routine with the family, by the end of the infancy or beginning of toddlerhood. The hope is that when parents do their jobs with the feeding, then children should do their jobs with the eating. So the parent, would be choosing and preparing the foods, providing a regular meal and snack schedule, trying to make meal times pleasant, kind of being considerate of the children's kind of lack of experience with eating, but trying not to cater too much to sort of likes and dislikes, because then they'll never sort of learn to like something. And then avoiding, having food or drinks except water right before meals. And then encouraging, but not forcing, eating several food groups. And you can include some kind of, age appropriate explanations on this about, needing some energy to run around. We're saving this food for later. This food was expensive, any allergies, things like that, to kind of explain why we're, doing a bit more of one food than another. And this model, we want parents to trust that their child is going to eat the amount that they need, and learn to eat, the foods that the rest of the family is eating, and grow, predictably in a way that's right for them. And then some mealtime pitfalls. So grazing, I know I hinted at that on the last slide, but that's an important topic that both Tessa and I address a lot in our feeding clinic. Even if there's growth concerns, we still want, some structuring and to not have too much grazing. Because if we're grazing all day on, drinks aside from water and snacks, that means we'll never really build up a full appetite. And then we won't eat as much at the meals. And the meals is typically where we'll have more nutrient dense foods being offered. After 1 year, our goal schedule is about 3 meals, 1 to 2 snacks, and then the appropriate amounts of milk. So I know I mentioned from 1 to 2 years old, 16 to 24 ounces of whole milk. At past 2 years, 16 ounces of low-fat milk, and then avoiding juice. It takes up their appetite, but doesn't come with a lot of nutrition. So we'll talk about on another slide. We want to get those nutrients from fruits, veggies, smoothies, or maybe something like a multivitamin. For Tessa.
I think it can be so challenging to maintain that mealtime structure into toddlerhood. It can be challenging to feel like you're saying no or restricting foods, and we really don't want it to feel that way. It's important to remember you don't have to say no. You can't have strawberries and goldfish. You can say, great idea, let's have strawberries and goldfish. That our snack is in 20 minutes, and that's when snack is. And so let's put those aside. So it feels a little bit more like we're saying yes, but we have to do something first. Sometimes a visual can be really helpful with maintaining that structure. So one thing I use a lot with my kids and with my patients is a visual timer, which is a timer with a kind of color that runs out with the time. 5 minutes, 10 minutes is a really abstract concept for kids really up until probably age 5 or 6, versus being able to visually see the time run out is a little bit more concrete and helps them understand how long they have to wait. So I use that a lot. The other thing that can be helpful is a visual schedule, or even talking through a schedule. First, we're going to go for a walk, then we're going to have lunch. First, we're going to play, then we're going to have snack, that sort of thing. And again, like Simona was mentioning, this is all in the name of really helping them understand their hunger and fullness cues. It doesn't mean that we have a meal at exactly 12 p.m. on the dot every single day. And of course, life is life and things get moved around. It's really more about letting them kind of have that time between the meals to get hungry, eat a full meal, feel what that fullness feels like, versus kind of grazing and sort of taking a couple bites throughout the day to kind of take the edge off the hunger. And then we end up not learning quite as much about our hunger and fullness cues. Screens. This is really tempting to involve screens in mealtime because just like adults, kids may eat more and may eat things they would not otherwise accept if they weren't in front of a screen. So there are a few reasons that we really generally recommend against this practice. The first is that kids are really good at knowing when they're hungry and when they're full when they're little. And this is something that we can train them out of if we're not careful. They have great insight into their bodies in that way. If we're using a screen to get more in because as parents we don't think they're eating enough, we can kind of untrain that insight a little bit, because we really have no idea, no way of knowing how much their body needs. They only know that, and sort of getting our information from their growth chart and what they're telling us is the best way to go about that. So using the screen to kind of override their fullness cues is not something we generally recommend. We also know that kids who eat new or less preferred foods when they're in front of a screen are not any more likely to then eat that food the next time they see it. And the reason for that is because the reason it works is the screen is distracting them from that sensory experience. So they're not really learning about the food when they're eating it in front of a screen. So yes, they may have a piece of broccoli while they're in front of a screen. No, they're not super likely to eat broccoli next time you serve it at the dinner table. And one last reason is that we're often modeling how to eat new foods for our kids. If they're watching a screen, they're missing out on that modeling and just generally sort of the social experience of the mealtime. I think we can sometimes get so caught up in the calories and nutrition aspect of meals that we can forget about how important the cultural and social piece is too. Short order cooking is this idea that we are making preferred foods for our kids after they reject what we've made, and sort of letting them dictate what they're having for dinner. um, if we present a food option and they refuse it, and then we make them a preferred food, we just pretty strongly reinforced that behavior of refusal. So now, anytime there's something new or non-preferred, that refusal is going to be pretty immediate because they know they can get their favorite food. That is not to say that we can't provide food that our child likes, but that we need to hold boundaries when it comes to how those foods are presented. So if you're serving a new meal to your child, we generally recommend presenting it along with a safe food. So, for example, if you are introducing salmon, and then they love mac and cheese, I would offer them together. Sometimes the outcome of that is that all they eat is mac and cheese. But if the alternative is we offer salmon, they throw a big tantrum, the salmon disappears, and then mac and cheese appears in front of them, they still would only eat mac and cheese, but we took out this power struggle by offering them both. So there is really great data to support this idea that we can get them used to having those non-preferred foods on their plate and then give them that sensory experience of like, what does this look like? What does it smell like? There's also pretty good data that once kids start eating, they tend to keep eating. So they may surprise you and kind of circle back to that food that they would have otherwise refused if it was offered just on its own. Often when kids are requesting certain foods and then refusing those foods when you give them to them, like, I want a pouch, and then you give them a pouch and no, I never wanted this, and what are you talking about? They're really looking for control around eating, which is really common. It's great to offer them control in other ways. So giving them what's called a forced choice, which is, do you want a red pouch or a green pouch? Then all of a sudden they have a little agency and they feel a little bit more in control. Putting them in charge of ringing the dinner bell is an idea that a lot of kids love and can kind of help get them to the table in a positive way. Putting them in charge of serving themselves and the other people at the table. Toddlers and young kids love a job. They love to have a job to do and to feel grown up. So those are all really nice options. Okay, dessert. Okay, so this is a bullet point. We gave this talk a couple years ago, and we added this one in because there was a lot of questions at the end about how we handle dessert. I know, you know, toddlers naturally gravitate towards some of these foods that we're having for dessert. So it can be very tempting to kind of use that as a tool to get them to eat more of what you're offering for dinner. And generally speaking, we want to avoid doing that. It's really tempting. So, for example, you need to eat 3 bites of broccoli and 2 bites of chicken if you want to have ice cream. What we're then doing when we do that, number one, is telling them that broccoli is really gross and boring and a slog, and I have to get through that in order to get the prize, which is the ice cream. So we're really like elevating ice cream up onto this platform and making all these other dinner foods a real chore to kind of get through. And the other side of that is that if we're making ice cream contingent on how dinner went, we can sometimes, again, get in the way of that fullness cue, right? We're going to teach them to eat more for dinner in order to earn dessert. And then they're going to kind of overeat when they get to dessert because they ate more dinner than they would have otherwise eaten. So, I generally recommend not making dessert kind of contingent on how dinner went. Whether you're a family who wants to offer dessert at the same time as dinner, which some people do, or after, as long as that either one's fine, as long as it's not like you have to eat a certain amount in order to get this. And some people like offering dessert with their meal because it sort of evens the playing field. These are all foods that are for dinner, and kids will often start with the dessert, but then they might circle back around to the dinner food. So that is an option if you're feeling really brave. Another common pitfall, which I'm absolutely guilty of with my kids, is taking foods out of the rotation. So we know it can take multiple, and I'm talking about possibly dozens of presentations of a food before a child will interact with it or eat it. If we offer broccoli 5 times and then we decide my child doesn't like this, they never eat it, and then we stop offering it, they're never going to learn to like that food because they don't have any more practice with it. So even if your child consistently ignores it or doesn't eat a certain food, always offering 1 or 2 pieces for practice and exposure if it's part of the family meal. It's also helpful to get your kids used to the experience of having non-preferred food on their plate. It's no big deal, and that's what we're having for dinner. And the most common phrase in my house at dinner is, "You don't have to eat it. Thanks for letting me know you don't have to eat it." So I say that a lot with my 5 and 3-year-olds when they let me know I'm not a fan of this food. Great, you don't have to eat it, and like the pressure is gone. Pressure is the next bullet point, which is this is a tough one. We all want our children to eat all of the amazing foods that we enjoy, both from a nutrition standpoint and from a cultural and family culture standpoint. So it can be really challenging when a child rejects a food or says they don't want something, says they're full after 1 bite. All of that is really, really challenging as a parent. But we know from really great research that pressure, bribing, really excessive encouragement or praise, force feeding, all those things, they really only cause kids to push back and refuse more. So this goes back to that division of responsibility idea. When you serve a meal or snack, you're done. Like you did your job, you did great. They get to decide if that food goes in their mouth, and if it does, how much they're going to eat. The clean plate club philosophy that I think a lot of us grew up with is one that will likely prolong picky eating and unteach insight into fullness, which can be challenging sort of into adulthood. So, number one, if we're thinking about like, can you get 1 bite of broccoli into your child with force feeding? Yeah, I'm sure you can, but it's not going to lead to an older child or adult who loves broccoli. And that's really our ultimate goal when we're thinking about long term.
So moving on to some more of the nutrition side of things. So macronutrients include things, fats, carbs, proteins, whereas micronutrients, which are listed on this slide, are vitamins and minerals that our body needs in much smaller amounts, but they still do have important jobs in the body. So see, these are some common micronutrients of concern. So things like calcium and vitamin D. Some common sources are dairy or fortified pea or soy milks. But even though these are important, we still don't want excessive milk intake. So we don't want more than 2 to 3 cups a day, as then it affects absorption of iron and can cause anemia. It also affects, their appetite, their fullness. So then they'll eat less of different foods. Iron is an important one for brain development, found in protein-rich foods or iron-fortified cereals. Vitamin C in fruits, veggies, smoothies. We do prefer smoothies over fruit juices, as then you'll get all the fiber and nutrients from the fruit, and it's less concentrated in sugar. And then we also have some sources of vitamin A there, which is important for, eye development. And then I commonly get questions around if children should be taking, supplements. The body does prefer and best absorb nutrition when it's from the diet when possible, but there are, of course, some times when supplements are needed. The American Academy of Pediatrics recommends for partially or exclusively breastfed infants to be on a daily vitamin D supplement. And then at 4 months, add an iron supplementation until there's enough iron-rich foods in the diet. So that iron recommendation might mean, replacing a vitamin D drop with an infant multivitamin that has both iron and vitamin D, especially if you're having some difficulty adding in those iron-rich foods. And then for babies that are born premature, they'll often be on iron supplements as well, as they missed out on some of that last trimester where they would have been, accumulating some of mom's iron stores. And then for toddlers and children, the pediatricians do on the heel or finger prick at 1 year to check for lead and anemia. They'll just draw a little bit of blood. So that will help decide if they need iron at that point. Again, since it's so important for brain development. For vitamins and minerals, it is, we don't want intake to be too low during these important periods of growth and development, but we also don't want intake to be too high. So typically we would suggest just an age-appropriate multivitamin, especially for really, picky eaters or medical conditions like food allergies or GI conditions or, multiple food allergies. And the children's multivitamin should provide, reasonable amounts of multiple vitamins and minerals, which is what we prefer. We don't usually suggest, specific individual supplements unless, there's a concern for a missing nutrient in the diet or a provider has found deficiencies. And then for more, severely limited diets, especially, when it comes along with, slow growth, then you might be suggested to do a pediatric formula, for an older child instead of milk, like Pediasure. And in cases where it's medically necessary, sometimes we can also get insurance to cover the cost of that. When to refer for a feeding evaluation. So I know we talked about, how everything should go, but we know that, isn't always how things actually go. So if they're accepting less than 10 to 15 different foods, concerns for kind of aspiration, choking, anxiety and stress surrounding meal times, behavioral considerations like refusing to self-feed, needing lots of screens, significant gagging with feeding, delayed texture progression. And then so that's a feeding evaluation, when to refer for a more multidisciplinary feeding clinic. So, one that would have multiple, medical providers included. If there's gastrointestinal concerns like constipation, diarrhea, vomiting, growth concerns, considerations about tube feeding, nutritional deficiencies, missing full food groups. An example of a multidisciplinary clinic would be our Mass General Hospital for Children Center for Feeding and Nutrition, also called our feeding clinic, where Tessa and I both work. And keeping in mind that some of the pediatric specialty clinics, both at MGH, but also at other places, may have some feeding related providers. So that would include speech language pathologists, gastroenterologists, dietitians, occupational therapists, maybe embedded within them who might be able to assist. So I know here at MGH, our Down syndrome clinic, our food allergy clinic, our airway clinic, and some others will have that. So that can be a good first place to start. And then here is our contact information, and we are happy to answer any questions.
Yes. All right. So we got a few questions. So one question we got from a viewer was, my elementary school age child often feels hungry after school. but it's
Mhm.
still too early for dinner. Do you have any tips on what to do so it doesn't spoil their dinner appetite?
Yeah. Do you want to go, Tessa? Or I'm sure we'll have
Sure.
some answers. Yeah.
Sure. Yeah. This is a really common one. I think a lot of kids don't eat quite as well at school. They have such a short time for meals when they're there, and it can be super distracting when they're with their friends. So they're not like having a super robust meal when they're at school. I think it's totally fine to offer a snack at that time. Sometimes I'll recommend doing like a little bit more of like a fruit and veggie forward snack. So that like you're getting a little bit more bang for your buck. Generally, like if we can leave 2 to 3 hours between that snack and dinner, that's what I would recommend. If it's not possible, then it sort of just is the season of life that they're in, because I don't really recommend having them come home starving and then waiting all the way till dinner. I will say, if we can have dinner, if the difference is like 3:30 snack, or could we just make dinner super early at 5 o'clock? I'd rather have an early dinner, but that's not always practical for a working family either. So I don't know that there's a great solution to that. I think, again, having that kind of fruit and veggie plate while we're waiting for dinner to get prepared is not going to fill them up a ton, and also may give you a little bit of extra nutrition that is not getting in the way of dinner quite as much.
Yeah, I would agree with that. It's kind of about the timing, and also, is this just like every once in a while, or is this kind of every day? And is there any wiggle room on the snack timing or the dinner timing? Or yeah, sometimes we can even maybe sneak something in just on the way home so that it's a little on the earlier side. Yeah, looks like you might be muted.
Sorry. All right, and then awesome. So our next question is for this age group, do you have any thoughts on giving them multivitamin gummies?
Yeah, so I know for some infants and toddlers, it tends to be more liquid options for those who need it, and then as they get older, gummy multivitamins are an option. Again, if they are eating, most, something from each food group, even if there's a little bit of pickiness, usually they may not need the multivitamin, but if you have some concerns, it's definitely fine to add that in there, because at least the kids' multivitamin has a nice kind of mix of, kind of age appropriate vitamins and minerals. We do, use some of the gummy forms if that's what the child is most likely to accept. The only downside there, though, is just that there may not be, a lot of iron in there. But if they're, having some proteins or iron-rich foods, then that may not be a concern. But yeah, you can't get nutrition from something that the child won't accept. So if there's this perfect multivitamin that you purchase and really want them to take, that they won't take it, they're not. We'd rather them, be getting nutrition, better nutrition from something that they will more regularly accept.
Nice, good to know. All right, our next question is whether either of you have tips on safely introducing solids to babies and monitoring for any potential allergic reactions.
I can take a little bit of that, Simone. I'm sure you have some thoughts too. I think we had mentioned early and frequent exposure with allergens is really important. Some families are really stressed out, so they put it off and wait until 9 months, 12 months. We know that that actually increases the risk of allergy. So as scary as it is, we do recommend doing it as close to 6 months as possible. Honestly, I've had tons of families who will like drive to the parking lot of the ED and sit in the parking lot and do peanut butter. And that's completely, totally fine if that's what you need to do to feel safe doing it. Or like at your child's 6 month well child visit, offering them some peanut butter or egg or whatever it is that you're working on. Generally, we recommend offering it when you know they're going to be awake for a couple of hours, so not before a nap, so you can just keep an eye on them. And knowing that sometimes an allergic reaction can happen on like the second, third, fourth introduction and not the first. So just keeping that in mind for being able to kind of monitor them and keep an eye on it. Um, I think that sort of answers the allergen question. I don't know, Simona, if you had another thought on that.
Yeah, I guess, yeah, that I agree with all that. Stealing some things I hear from our food allergy clinic providers a lot. Yeah, they would agree with those. And then, also maybe not introducing a top allergen food when they're having other illnesses or other medical issues so that you don't confuse that reaction with, something else that's going on. And yeah, it can happen sort of after, a few tries of having something. But, the research is showing that it is, important and helpful to get those in early to actually reduce the risk of allergies later on. So even though it is scary, it is helpful to kind of do that sooner. And sometimes people will, tag in, other friends or family members who, may kind of be there for support, or like you mentioned, kind of doing it in certain settings where they feel more comfortable. Yeah.
And I think there was a question about sort of how to safely introduce solids. I think my number one tip would just be giving the baby as much independence as possible. It's much more likely that they are going to choke if you are the one trying to feed them when they are not interested in being fed. So giving them the spoon, letting them pick up the piece of food that they're going to put in their mouth, all of that really reduces the risk of choking. And again, taking a CPR and an infant choking course, because I think that helps with the confidence of what you would do if there was something that were to happen.
Awesome. Well, thank you both for speaking with us today. And I'm just going to pass it along to Amy to close us out.
Thank you. Thank you all for joining today. As I mentioned, today's session is being recorded. It'll be made available on the Blum Center website. I'll probably would give it about a week or two. I put that website link in the chat. It's massgeneral.org/Blum-Center. Thank you, everyone. Take care.
Thanks, guys.